Welcome to Think Like a Nurse, the video outreach of Keith RN. My website is a weekly blog that promotes outside-the-box thinking to transform nursing education. Today's video blog topic, I see dead patients. In the landmark study by the Institute of Medicine in 1999 titled To Err is Human, Building a Safer Healthcare System, identified that preventable human errors by medical staff were responsible for 44 to 98,000 deaths annually in this country. These findings have since radically impacted clinical practice as needed reforms have been embraced. Timeouts before any medical procedures and barcode scanners for medication administration are some practical interventions that have been successful to reverse this needless loss of human life. In order to fully embrace and pursue the radical transformation that is needed in nursing education, which the Carnegie Foundation research identified and made painfully clear in the bestseller book, Educating Nurses, A Call for Radical Transformation, both students and educators must step back and ask, what is the ultimate consequence when a nurse fails to think like a nurse? By clinically reasoning and recognizing a change of status until it is too late. A patient will die needlessly and before their time. I see dead people was a famous quote by a small boy named Cole Sears in the movie The Sixth Sense in 1999. Fortunately, it was only a movie. As a nurse, I see dead patients. And some have died as the result of a nurse who failed to rescue their patient with a change of status until it was too late. I've experienced this firsthand when a nurse colleague on a medical floor had a patient who was sliding into sepsis during the night and clear warning signs went unrecognized until the morning. And I was called to assist. But by this time, the patient was pale, diaphoretic, and his respiratory rate had increased to 40 breaths a minute. He was not responsive to loud verbal commands. The last blood pressure was still on the screen and read 158/90. I asked, when was the last blood pressure done? It was 4 hours ago. While obtaining another blood pressure, I touched his forehead. It was notably ice cold, as were his hands and his feet. The blood pressure now read 68/30. He was emergently transferred to ICU within 30 minutes. He was intubated, a central line was placed, and 3 vasopressors were started to get his blood pressure greater than 90. Unfortunately, he died the next day. This patient is likely not the only one who died because a nurse failed to think like a nurse. Many of you also, who are nurses or nurse educators, also carry a secret. You too know of a nurse, or may have been that nurse, who through inaction, busyness, or lack of vigilance caused harm to your patient that contributed to a bad outcome. As nurse educators, we must not fall into the trap of seeing clinical reasoning as a trendy pedagogy or a new way to flip our classrooms to do something different. Clinical reasoning is a transformational paradigm shift from educating nurses and the Carnegie Foundation research that is educational best practice that must be situated in our nursing curriculum. Clinical reasoning defined as simply this: the ability of the nurse to think in action and reason as the situation changes over time by capturing and understanding the significance of clinical trends as they're sliding and grasping the essence of the clinical scenario. Now, NANDA, nursing diagnostic statements, can be a barrier to identifying the current care priority when the status of a patient changes. That is why NANDA can be a no-no in practice. Dorothy Del Bueno identified this problem when she found in her journal article, A Crisis in Critical Thinking in 2005, that new nurses were unable to exercise correct clinical judgment at a basic level to rescue their patient and identify the problem and intervene in a simulated scenario. And what was the reason? Inappropriate use of NANDA nursing diagnostic statements to make them fit when there was a change in status. And therefore, nurses failed to rescue their patients in this scenario. So part of the needed transformational needed in nursing education is to de-emphasize NANDA and emphasize clinical reasoning. A key finding of the Institute of Medicine report was that medical errors were not the result of incompetent medical staff, but more commonly, errors are caused by faulty systems, processes, and conditions that lead people to make mistakes or fail to prevent them. What does this have to do in nursing education? Everything. In nursing education, we too must recognize that we are part of the problem. We too have a system issue that needs to be changed and fixed. It is not incompetent educators that is causing this crisis in critical thinking in our graduates, but an emphasis on NANDA for 30+ years as the primary way to establish a care priority. This needs to change because tomorrow may be too late, because patient care and outcomes are impacted by our graduates being unable to graduate and think like a nurse at the bedside. Clinical reasoning and the lack of it can literally be the difference between life and death. If needed change is not made soon in nursing education, the next Institute of Medicine report may be headed our way in nursing education. It could be aptly titled, To Think or Not to Think, Building a Safer Nursing Education System. But let us do all that we can today as nurse educators to situate clinical reasoning throughout our curriculum so this report never happens tomorrow.